Dr. Aniruddha Datta, who is also a student of Professor Rai Choudhury, and he will be telling some ASCII questions. And after that, there will be some important trial discussion, third part on this topic. So without wasting much time, because Madam has got some engagement after that, so we can start. Can we start, Madam?
Yes, of course.
Yes. So Dipankar, you start. You try to keep your history within maybe 10 to 12 minutes of time, so that we can get more time for discussion. And you can start now.
Thank you, sir. Respected teachers, my dear seniors, colleagues, and juniors. Today I'm going to present a case of 23-year-old female hailing from Murshidabad, came on postpartum day 10 with decreased urine output, bilateral lower limb swelling, frothy urine, and she completed her and a history given by herself, and it was reliable. Now I'm coming to the history of present illness. I would like to begin my history from her pregnancy period, which was detected after her last menstrual period dated on 1 February 2024 via urinary pregnancy kit test. After which she was gone through regular antenatal checkup every month, and her all antenatal reports and USG was normal. She felt her first quickening movement on fifth month of pregnancy. There was no history of raised BP, fever, UTI, excessive vomiting, any feeling of lower urinary tract symptoms during her pregnancy period. Her frequency of urination was around 5 to 6 times daily with no history of nocturia. Her expected delivery date was around 7 November 2024. But 7 days before delivery, she suddenly experienced dull aching lower abdominal pain, which has not subsided on taking medications. And there was also progressive blurring of vision with holocranial headache. Her BP at that time was around 160 by 100 millimeter of mercury. She immediately consulted her gynecologist, and there was no history of any excessive pervaginal bleed, foul smelling vaginal discharge, a loss of consciousness, seizure, lower limb weakness at that time. She can't remember about the blood investigation done at that time. And the gynecologist performed a lower segment cesarean section with 2 unit blood transfusion after that. The birth weight of the baby is around 2.3 kg with no history of and with no immediate complication. Her post-delivery, there was no history of fever, pain abdomen, foul smelling, pervaginal discharge. After delivery, the patient suddenly developed decreased frequency of micturition. There was not associated with burning micturition, hematuria, pain abdomen, and the color of the urine is dark yellow. She also developed bilateral lower limb swelling up to ankle joint, which was sudden in onset with no associated, and there is no associated with facial puffiness, shortness of breath, palpitation. Chest pain and fever, dry cough, orthopnea, abdominal distension, and yellowish discoloration of the eye. For the blurring of vision, opinion by ophthalmologist was taken, and 1 dose of injection steroid was given. For the first time, she was informed by her gynecologist about her blood investigations. Blood reports showing there was raised creatinine, but she can't remember about the value. She was also informed that there was leakage of protein in her urine. Her BP at that time was around 150 by 100 millimeter of mercury. Her postpartum USG showing there is written product of conception. Initially, she was managed with antihypertensive medication along with intravenous antibiotics. She has been discharged after 4 days with slight decrease in creatinine and stabilization of blood pressure, and advised to follow up in OPD. But after 3 days of discharge, the condition of the patient deteriorated with decreased urine output, uncontrolled blood pressure, and bilateral lower limb swelling. So the patient was again hospitalized. Her creatinine at that time was around 5.9 millimeter per deciliter, as told by her physician. Initially, she was managed with intravenous Lasix injection, IV antibiotics. As the condition of the patient deteriorated, she has been referred to our hospital for further management. Now coming to the negative history. There is no history of passing blood in the urine, nocturia, burning micturition, cola color urine. And there is no history of hemoptysis, arthralgia, oral ulcer, hair loss, photosensitivity. There is no history of bone pain, fracture. There is no history of fever, cough, vomiting, loose stool, skin infection, ear discharge. There is no history of taking any NSAIDs or herbal medication. Now coming to the obstetric history. She is gravida 1, parity 1. This is her first pregnancy after 2 years of marriage. There is no history of fetal loss. There is no history of raised blood pressure, albuminuria during her entire pregnancy period. During her pregnancy, her investigation report was normal. She was vaccinated with TT injection and she is on regular yeah. She was regular medication with calcium, folic acid, iron tablets. Now coming to the past history, there is no history of similar episodes in the past. She is not a known case of hypertension, diabetes, and thyroid disorder. Now vaccination history. Her vaccination history is up to date according to the vaccination schedule, and there is a BCG scar mark in the left upper arm. Now coming to the present personal history. She is married for 2 years with no history of smoking, alcohol intake, and her bladder and bowel habits are normal. Now coming to the family history. There is no history of any pregnancy-related hypertensive disorder in her paternal and maternal side. She and her brother born via normal vaginal delivery with no history of any complication. And there is no history of any kidney disease in her family. Now coming to the menstrual history. She attained menarche at 13 years of age with regular menstrual cycle.
So with that, can you summarize? And if you have gone through a urine routine examination, please tell
Yes,
that.
ma'am. Okay, ma'am. I will
And
just
important points of positive and negative points of physical examination. Give a
okay,
summary,
sure.
important
Okay, ma'am.
positive and negative points of physical examination, and a urine
Okay,
routine
ma'am.
if you have gone through.
Okay, ma'am. Okay, ma'am. Now I'm going to summarize the case. My patient, a 23-year-old female, married for last 2 years, Islam by religion, working as a housewife who was admitted for emergency lower segment cesarean section with the indication of pregnancy-induced hypertension and delivered a male child of 2.3 kg who cried immediately after birth on 1 November 2024. Then she suddenly developed oliguria immediately after the delivery, followed by volume overload, for which she was put on 3 sessions of hemodialysis. And during this time, she also got 2 units of PRBC. And eventually, her urine output gradually improving up to 1.5 liter in 24 hours. Now, coming to the general examination, the patient is conscious, well oriented to time, place, and person. The height is around 155 centimeter with BMI is 25 kg per meter square. Pulse rate is 96 per minute, regular and regular in volume, and no radial, radiofemoral delay. Blood pressure is around 140 by 90 on right upper limb, and there is no significant difference of BP in upper limb and lower limb. Respiratory rate is
Any
around
important
18 per.
positive or negative points you want to mention, which is
Uh,
important for your patient and
Only,
history?
ma'am, in general examination, only in fundoscopic examination, there is only bilateral exudative retinal detachment is there. And in urine routine examination, there is 2 plus protein, plenty of RBC, and on quantification, it's showing 1.5 gram proteinuria in 24 hours.
Okay.
And in systemic examination, there is no positive finding in CVS, CNS, respiratory, and abdominal examination.
She doesn't have any anemia, jaundice.
Anemia, she has hemoglobin of 9.2. And
I'm not interested with the exact value. I'm interested with your physical examination, positive points of your physical examination, which are
only positive
important,
find in
relevant.
urine, there is only 2 plus proteinuria is there, and she is anemic, for which she was given 2 units of PRBC.
So there is anemia, there is no jaundice. And in specific systemic examination, if you have found something,
And there is no any positive findings, ma'am, in CVS, CNS, and respiratory examination.
For a hypertensive patient, what did you
Yes, ma'am.
expect? What are the organs did you examine for such a patient? What do you think that what you should see?
Mainly, ma'am, mainly we can look for, ma'am, any abdomen bruit for rule out renal artery stenosis.
So,
Any,
a female who
yes,
has come to you with pregnancy related AKI
yes, ma'am.
and gradually recovered after a period of dialysis requiring AKI,
Yes, ma'am.
do you think that you should think of any systemic autoimmune disease also? A
Yes, ma'am.
female of childbearing age presented first time with PRAKI in pregnancy.
Yes.
Do you think, and in your systemic examination, will you be careful to look at if there any stigmata is there? You have
Um,
mentioned the negative history of other
yes,
systemic involvement.
yes.
In your
Ma'am,
important negative history, some
ma'am,
of
we can,
those,
yes, ma'am. We can look for any skin rashes, oral ulcers to rule out lupus with uh,
yes. So,
apna.
so childbearing age,
Yes,
lupus may be present
yes,
with the pregnancy induced hypertensive disorders.
yes,
Lupus may be present.
yes.
Her urine does have proteinuria 2 plus
Two plus.
without any active sediment.
Yeah,
Okay.
yes.
Okay. So what is your differential?
My syndromic diagnosis will be pregnancy-related AKI, and
Hmm.
etiological diagnosis from preference-wise, first will be pregnancy in preeclampsia, followed by abruptio placenta, followed by glomerular disease, then thrombotic microangiopathy, and then in last acute tubular injury.
Yes.
I am interrupting, madam. Can you on your video?
Oh, of course, of course. Sorry. I had initially put on some time back. Okay. So uh, you think that preeclampsia is your first diagnosis. I
Yes, ma'am.
agree. But what are the important points in favor?
Ma'am, at first the BP is around, initially the patient has no history of hypertension and she developed BP after 20 weeks of gestation. And there is holocranial headache is there, and there is some blurring of vision is there. They all manifestation of organ involvement with high BP after 20 weeks of gestation. All it favor
So,
goes
so
to
will you like
PHM.
to put one adjective before preeclampsia that it is severe preeclampsia?
Yes,
Isn't it?
yes,
So
ma'am.
what is the recent change in the definition of preeclampsia? Can you,
Ma'am,
from the finding, can you tell that he does have preeclampsia even without an urine examination?
yes, ma'am. Previously, before 2013, American College of Gynecologists, there is only for definition of preeclampsia, there is only proteinuria with high BP is there. But now there is BP if more than 140 by 90 on two occasion, 4 hours apart, with proteinuria, and then thrombocytopenia, DIC, or any fetal distress, or any organ transaminitis is there, then you can go call it a preeclampsia, ma'am. And
So what are the other target organs which have been included in the definition of preeclampsia other
uh,
than kidney?
from hematological point of view,
So
thrombocytopenia,
hematological system is one, two,
then liver.
liver,
Third one is, ma'am, neurological manifestation will be there.
yes, neurological,
Then cardiovascular involvement is there.
yes, acute severe pulmonary edema, which you can
Yes,
call
ma'am.
as
Yes.
uh, pul- cardiovascular manifestation. So there is a change that even without proteinuria, now we can label preeclampsia. So without urine examination, also you can tell that this is a case of severe preeclampsia.
Yes.
how do you add this severe preeclampsia? Why I have added this severe preeclampsia?
Ma'am, if the patient has normal preeclampsia, then it can be managed in
No,
outpatient wise.
not
But if,
management, but at the presentation, BP was very high, and other neurological involvement is there,
yes,
abdominal pain is there, which
yes,
suggests that there might be hepatic involvement
yes, ma'am.
pushing the patient to some severe symptom. What
Yes,
is
ma'am.
the outcome difference in preeclampsia and severe preeclampsia?
Ma'am, yeah, in case of ma'am preeclampsia, there is both maternal and fetal side. There is both short term and long term outcome will be there. For short term outcome, there is it may cause peripartum cardiomyopathy, myocardial infarction, or heart failure. In long term, the maternal side, there is a high risk of hypertension and coronary vascular disease will be there.
In short term, what other maternal problems can happen? It can be, you told, it can be directed to some cardiac issues which are usually volume overload related, and
Yes,
there are
yes,
some other propositions also regarding cytokine based or something.
yes,
Or there are hepatic, some patients may come with acute renal failure, some patients may
yes,
come with acute hepatic failure. So, from maternal point of view, short-term bad consequences in preeclampsia may be, in severe
yes,
preeclampsia may be all these. But usually, in not, which is not a severe preeclampsia, the all the process stops whenever your baby is her baby
very
is
good.
delivered.
Yes,
Yeah?
ma'am.
Because the renal change in usual preeclampsia is only, what is the histological change in preeclampsia? We do not do a placental biopsy or a renal biopsy, but really, if
Yes.
we subject the placenta to biopsy, what we will see, or a maternal kidney to biopsy, what we will see?
If the placental biopsy will taken, it will mainly show trophoblastic necrosis will be there. And if the we'll do any maternal kidney biopsy, then we'll see mainly endothelial cell swelling will be there.
Yes. So we call it endotheliosis. Very good.
Endothelios.
So we call it endotheliosis. That will be the only change.
Yes.
But when, or there might be some changes of the acute tubular injury there.
Yes.
But what happens if there is severe preeclampsia? It can be directed to any severe organ damage, as I was talking earlier.
Yes. Yes.
What happens with the fetal outcome?
Ma'am, fetal short-term outcome will be there is preterm birth will be there, or there is intrauterine growth retardation will be there. In long-term outcome, there will be they are more prone to CKD, as
Why?
there is low because if the patient grow actually the kidney maturation take time at around 36 of gestation. If they will born before 36 will month, and then due to nephron endowment.
So
There
we
will be
always suspect that the baby might be born with low number of nephrons if he
yes,
is
ma'am.
born preterm.
Yes,
Even
ma'am.
with advanced neonatal care now available,
Yes,
we can
yes,
support the baby and push the
yes,
baby to normal growth and everything over period
yes,
of time.
yes,
But
ma'am.
we may face a severe, we may face a later part of life, the baby
Yes,
might proceed to CKD. That is always a uh,
yes,
apprehension behind.
yes.
So, what are the other types of hypertensive disorder in pregnancy?
Ma'am, first is chronic hypertension. The second one is gestational hypertension. Third one is preeclampsia. Fourth one is severely preeclampsia.
No. Fourth is chronic hypertension superimposed with preeclampsia. We
Yes,
take preeclampsia and severe preeclampsia on the same board,
yes,
and
ma'am.
we take, so chronic hypertension
Yes,
may go on throughout the pregnancy, controlled with medication or so, or
yes,
it may be superimposed with preeclampsia.
yes, ma'am.
Naturally, when superimposed with preeclampsia, then the
Yes,
outcome becomes worse.
more.
And uh, There are other two hypertensions, gestational. What is gestational hypertension?
Gestational hypertension is when the BP is more than 140/90 on 2 occasions, but there is no organ involvement is there after 20
Yes.
weeks of gestation.
What happens in the postpartum to gestational hypertension, and what happens in preeclampsia? With what
Ma'am,
we should be
in
more
postpartum
cautious?
period, yes.
With what
Ma'am,
type we should be more cautious?
ma'am, actually, for gestational hypertension, will be more cautious. Because 1/3 of gestational hypertension will change to preeclampsia.
So nowadays, postpartum is also called the fourth trimester. If a patient is suffering from preeclampsia, what important warning signs you take in the fourth trimester?
Ma'am, we actually, if there is a overlap between the preeclampsia and HELP, then we look for CBC.
Suppose there is no help, there is only preeclampsia. There is
Ma'am,
either gestational hypertension or preeclampsia. What you will be looking after in the fourth trimester? When you discharge the patient, what you will say to the patient? Suppose
ma'am,
there was a transient renal dysfunction, the gynecologist involved you in the management of the patient. Then what warning you would give to the patient?
ma'am, we only look for a BP monitoring for next 6 weeks, ma'am. If there is a
6 extended to 12 weeks. So
yes,
we should ask them to monitor BP for 12 weeks. And not only that, explain them that these patients might get hypertensive. So even if after 12 weeks, the later on, and can have a CKD sequela or CVD
yes,
sequela. So push that warning with them that they might need time to time blood pressure monitoring
yes,
and renal function monitoring too.
yes,
Sometimes patients come at 30, 35 years without any known glomerular disease,
yes,
without any known cause of CKD, and they progress to dialysis dependence. If you ask them, you will find that they had a PET episode.
yes, ma'am.
So there later on, they may have a cardiovascular sequela or a
Yes,
renal sequela.
yes,
So whether chronic hypertension superimposed with preeclampsia, which
yes,
is always dangerous, can have a permanent organ damage sequela. About preeclampsia and gestational hypertension also, we should
yes,
take these warnings in the for the fourth trimester.
yes,
So you have two admissions in fourth trimester. And
yes,
one important question as well, you have labeled as AKI. You have given some points in your history
yes,
that the patient is not a known kidney disease. Sometimes it
yes.
may go unnoticed. What are the points in your history that shows that it is a PRAKI truly? It's not chronic. I can say the patient had anemia, the gynecologist transfused blood, so it might be a chronic injury only.
Ma'am, during her antenatal period, her BP is well controlled, and there is all during antenatal checkup, her blood report was also normal, ma'am. There is no
What
any
is the usual
abnormality in
what
kidney
is the
function.
usual BP change during the physiological pattern of BP change? Suppose I'm a hypertensive and I have a BP of 150/90 usually. How I will do when I'm in the first trimester of pregnancy, second trimester, or at term?
Ma'am, during first trimester, there is a decrease in systemic vascular resistance. So there will be decrease in BP. Then
So
after
even in a mild hypertensive, you may get a normal BP throughout the second trimester. So after, so that is not a guarantee that you are not looking at a chronic kidney disease patient, but you have provided a history, some history that she is not like unlikely to be CKD.
yes,
You mentioned,
yes, ma'am.
yeah. One, she did not have any comorbidities that can push to CKD.
Yes,
Number two, recognized comorbidity was not there. Number
yes,
two, she did not have any nocturia.
Nocturia.
Usually we'll link, yes, you told this symptom, but you forgot to link between. So we usually take nocturia as a signal for CKD.
Yes.
Yes. So what do you think that she was an acute kidney injury?
Acute kidney injury.
Yes. Any other point to support your diagnosis?
There is platelet count is slightly low, and there is BP is around more than 160/100 with headache, blurring of vision is there, and it all occurs after 20 weeks of gestation, ma'am.
So when you told me the flow of the disease, then again you told me that she has recovered out of dialysis. So definitely there was an acute kidney injury pushing
Yes,
her to dialysis, from which now she moves into improved urine output and is now free from dialysis.
from
So
dialysis.
throughout the history, without going to investigations, you find a support to your diagnosis of AKI. Isn't it?
Yes, ma'am.
Yes. So Pratik, you want to put any question, or I will move? Pratik?
No, I will not ask any question. If you can discuss, maybe after I make.
Okay. So this patient had gone to dialysis dependent AKI. In the postpartum period, there were 2 admissions. During that period, there was blood transfusion requirement. So Dipankar,
Yes,
what do you
yes.
think? What was happening to her? Is it just preeclampsia, severe preeclampsia, or some other syndrome of extension of preeclampsia, or it is an abruptio, or it is what other diagnoses you have talked to me? TMA or
So, ma'am,
GN?
ma'am, it is look like, ma'am, abruptio placenta because the patient's complaining about pain abdomen and there is a decrease in output and the patient required 2 units of PEG RBC transfusion.
How common is abruptio placentae in preeclampsia? Why it can't be the HELP syndrome? The HELP syndrome, the patient will also have an abdominal pain
Yes.
and might develop anemia requiring blood transfusion.
Ma'am, platelet count is around 1,30,000 is there, and and there is no significant transaminitis is there.
Okay.
So,
So what are the marker? What are the words HELLP? What you are looking for?
for in HELP syndrome in main, we first look for any signs of hemolysis, like any cystocytes or helmet cell in the peripheral blood smear, and then we look for platelet count. If it is less than 1 lakh, then we look for a LDH count. If it is more than LDH is more than 600 unit per liter, then and it goes towards the HELP syndrome, ma'am.
Okay. So you have to take support of some investigations to exclude. And what other investigation also you require to establish your diagnosis of abruptio?
Um, for abruptio, we can coagulation
What is the
factor.
common complication of abruptio? And what is the important differential? If you don't go to the physical examination, abruptio placentae mostly comes with
Abruptio mainly pain abdomen will be there, and there is no in abdominal examination there we can palpate the uterus.
any other complaint for abruptio.
There will be profuse bleeding will be there.
There might be concealed or open bleeding. Bleeding
Yes.
might be concealed, might be open.
Yes.
And the patient might come in shock and in DIC.
Yeah, I see.
Yes,
Yes.
where you will find the abnormal coagulation profile.
Yes.
But in HELP, what happens to the coagulation profile? HELP and TMA?
In HELP and TMA, there is then mainly antifibrinogen will be increased, and there is a decrease in coagulation factor, mainly 2, 7, 9, 10, and in whole VWF and
All.
decrease. Yes.
In
And
TMA, there will be.
in TMA, there
What
will
is the
be
important difference between TMA and DIC? The
in
coagulation parameters are altered in
DIC, ma'am.
coagulation parameters will be abnormal in
DIC, ma'am.
yes.
There is
So
consumption of coagulation factor will be there.
consumption of coagulation factors will be there. What might happen in HELP?
In HELP, there is only platelet count will be low, and there
So
is
usually
hemolysis.
it is not. HELP may proceed to different outcome. HELP may, most of the cases, HELP also resolves after some days of delivery. But
Yes.
sometimes in 3% cases, it may go to a dialysis requiring acute renal failure. In again, 2-3% cases, it may progress to severe liver damage. And of course, if there is severe liver damage, the coagulopathy may appear then.
Yes.
And sometimes it may move to the extreme consequences of actually in HELP there is a preferential liver involvement, and in PAHUS or TMA there is a preferential involvement of the kidneys.
Kidneys.
Yes.
Yes.
So what do you think, whether it can be a TMA as well? Some
It
HELP
can.
patients can move to abruptio placentae as well. 2-3% can be associated with abruptio placentae.
Yes. Sir, it can maybe TMA because there is a renal dysfunction is there, thrombocytopenia is there, but yeah, LDH is not so high. It's around 300, and
So usually LDH is very high in TMA.
high.
Good. Good. Usually hemolysis is more in TMA, but that you cannot take it for granted. Actually, with TMA, we usually do not find such resolution. After 4 dialyses, the patient recovering, this
Yes.
picture is not common with TMA.
Yeah.
Often with TMA, we land with acute cortical necrosis and the patient moves to permanent dialysis. What is the important medicine that have changed the outcome of TMA?
Ma'am, eculizumab.
Yes. So eculizumab is one which has changed a little, but in most of the time, when you are taking the patient's history, the movement, the total dynamics of the patient adds to your diagnosis. No? So usually this recovery we do not see in a TMA patient. That's the went to, yes. So there might be, for argument point, there might be a patchy TMA and partial recovery, but at least the patient has recovered. And
Yes.
it might have been complicated by abruptio placentae.
Yes.
What about glomerular disease associated? One more thing. You had told me about some neurological symptoms. What
Yes.
other disease you may think you should consider when there will be some neurological symptoms?
Ma'am, didn't get you.
What other disease in this scenario you should think of when you consider a neurologic disease in the differential? In this picture,
Ma'am, it may be due to APLA, SLE with a flare up of SLE with APLA. It can causes, ma'am, neurological involvement.
it can be SLE with neurological antiphospholipid syndrome.
Yes.
That
Yes,
is
ma'am.
only, or something like TTP you have heard about.
Yes, ma'am. TTP, ma'am. TTP can causes neurological involvement.
TTP can cause a neurological involvement as well.
Yes, ma'am. Yes, ma'am.
Okay. So what happens with TTP? What is the usual starting point of TTP?
Ma'am, yeah, TTP mainly occurs in between second trimester to third trimester, ma'am.
Madam, please unmute.
So what are the important features? What are the important features in TTP? The clinical features.
There is a patient may have fever, thrombocytopenia, any neurological features will be there in TTP. And in pregnancy time, it mainly occurs in between second to third trimester.
Probably Madam is not connected now. So can you ask Madam to connect or? Yes. So Dipankar, what is your diagnosis at this point?
Uh, from syndromic diagnosis is pregnancy related AKI, and from etiological diagnosis it's preeclampsia.
Okay, just 1 minute. So, are you planning in this case the patient has recovered? You told the patient has recovered after some dialysis. In these cases, will you plan for some immunological workup or we just follow the patients?
Mainly we will do during pregnancy time, we mainly do an immunological profile as the patient has mainly in childbearing age. We'll mainly go for C3, C4, then ANA profile to rule out SLE. And also we'll do one urine routine investigation to rule out any, to see for any active urinary sediments, to rule out any glomerular disease.
So, for excluding lupus, so which investigation you want to do?
Mainly we do C3, C4 and anti-dsDNA.
So, how the complement level in the patients of lupus pregnancy versus patients of lupus without pregnancy? What is the difference? What will you
In
get the complement level?
uh, in uh, lu- in pregnancy time, the complement level are almost normal in lupus nephritis, but in non-pregnancy state, the complement level will be low.
Can you name some situations where you get a higher complement level, C3 level is high?
Uh, uh, One is cryoglobulinemia.
Cryoglobulinemia, you can get a low, is a, it consumes complement. Anything? Suppose this patient has a postpartum puerperal sepsis at the same time post-delivery. So in infection, what is the complement level?
Yes, sir. It's a mainly infection related, mainly in purpural sepsis. There is alternate pathways activated, so low C3 will be there.
This is of infection. We usually get in any common infection. If you do a complement level, you may get a higher complement level. Not it is a low complement level. Okay. And in pregnancy, what happens to the complement? Does it go
It's
down? Or
Sir, it's maybe
uncomplicated pregnancy.
it will go high, sir.
So that is the point. You may not get a low complement in spite of there may be an active lupus nephritis in these situations. Okay. And what other investigation you want to do?
Um,
So Madam has joined.
Yeah, I have joined.
If you just ask two questions, if you consider lupus in these cases, what investigation will you do, and ask 2-3 lines about complement, will be low or high. Then you take over.
so mainly we all go look for anti-phospholipid antibody. We'll see for anti-phospholipid antibody to rule out any APLA.
Madam, you can continue. Hello.
Pratik, will you continue?
No, you just continue, and if you want to sum up, then also you can.
No. I will take for another 10-15 minutes and then.
Yes, you continue for because there's some discussion, so you can continue about 7-8 minutes more. 8 minutes.
Hello. Yes, I will continue for 7-10 minutes.
Okay.
Where were we? Dr. Pratik was asking you that what are the GN cases, and we were discussing lupus. So a lupus flare might be there when pregnancy, AKI, and it might be manifest first time in pregnancy, may be complicated with lupus. And what are the findings in at 20 weeks or just before pregnancy that we have seen? What are the important differences between preeclampsia and preeclampsia with lupus? What are the investigations you would look at?
Ma'am, first in
প্রতীককে এটা
clinically.
জিজ্ঞেস করেছিলে? Have you asked this?
No, ma'am. No, ma'am.
Okay. So what are the
Ma'am,
investigations
first
you
we
would
have
look
to
at?
look for complement level. In lupus, the complement
Simpler
level
investigation
is
than that, which can give you some idea.
Simpler investigation is urine routine examination. We'll do one in urine routine examination. In
Yes.
lupus
So
nephritis,
what will you find in lupus?
we'll mainly find active urinary sediment will be there in lupus nephritis.
Yes, it is expected that you will find urinary sediments. What more investigation you are likely to send?
Ma'am, we'll send for dsDNA.
Preeclampsia, how much protein you? No. In preeclampsia,
Yes,
how
ma'am.
much protein do you expect in 24-hour urine?
In 24-hour urine, we expect more than 300 milligram.
More than 300 milligram. So with lupus,
It is
the
subnephrotic range
proteinuria magnitude may be
high.
Yes. The proteinuria is usually not 300, 500 when we see a flare. It is usually more, at least more than 1 gram, 2 gram proteinuria we see in lupus nephritis.
Yes, ma'am.
Yes.
Yes.
So, and telling that from there, suspicion that it might be lupus-related flare in pregnancy and lupus superimposed with preeclampsia.
Yes, ma'am.
Okay. So
Stop
then you will
so
have sent the ANA, anti-dsDNA, and other investigations to confirm that whether lupus is there associated with preeclampsia. What are the medications that you use for hypertension control in preeclampsia in a pregnant?
Ma'am, will the first drug of choice is labetalol. If labetalol is not available, then we
Labetalol.
can, yes, ma'am. If labetalol is not available,
You will use all beta blockers or some beta blockers you avoid? You will use all
ma'am,
beta blockers or some beta blocker you
no,
avoid?
ma'am, most of the beta blockers are avoid. We can use mainly propranolol, ma'am.
No, labetalol you use preferentially, and you
Yes,
never use the beta blocker that you should never use is atenolol. If you don't
yes,
get labetalol, you can
yes,
use should not work atenolol. Okay,
yes,
then
ma'am. Yes. Then the second drug of choice is
labetalol is not available.
Then nicardipine we can give it. We can give.
Then
Uh,
what more?
then we can go for methyl dopamine.
Yes. What is the side effect of methyl dopa?
There is a volume. There is volume retention will be there.
Volume retention or something else? Suppose this patient has come with pedal edema. Will you use diuretic?
No, ma'am.
Yes. What problem it might do?
Ma'am, yeah, it can cause RAS activation. It can
SNS activation and RAS activation. And
yes,
there might be
hypertensive emergency will be there, ma'am.
no. Anything related to amniotic fluid?
Uh,
Okay. So with that, we come to the uh, uh, other one cause of which you have mentioned at the lower end, that is TMA.
yes, ma'am.
Yes. So do you think that it can be a TMA as well? Some
Uh,
TMA can improve.
Ma'am, actually, TMA mainly it occurs in last periods of third trimester, and it worsen after delivery. But in these cases, ma'am, it gradually improving, ma'am. So it and platelet count is also in
That we have
borderline.
discussed. That
Yes,
is
ma'am.
why I have told you that some TMA may improve, which is not a likely picture.
Yes, ma'am.
Can there be some TMAs which may improve?
Ma'am, then there is a if it is a TMA, then the BP will be not controlled, ma'am. But in this case, the BP already controlled after taking antihypertensive medications.
No, that is not that. Okay, so with some TMAs, which are mostly antibody to CFH, they may improve without equilizumab.
Yes,
What you are then, what have, what is the extra dialysis sort of thing you would have done then?
ma'am, plasma exchange we can do or
Yes,
infusion.
plasma exchange we can do.
Yes, ma'am.
So we can, some TMAs may improve with to some amount with plasmapheresis.
Yes,
Usually in our setting, what we do, we usually immediately subject, if we suspect TMA, if the
yes,
LDH is too high or gradually becoming high, and we suspect TMA, what we do is to offer plasmapheresis to the patient.
we mainly
Even
do
if
plasma exchange.
equilizumab is not present, some patients who may be anti-CFH antibody related may improve with
Yes,
plasmapheresis
yes, ma'am.
and may need. What would you do with those TMAs if you don't have equilizumab in hand?
Then we can give in
We can give something which will not manufacture antibody in future? What would be that?
Mainly, ma'am,
You can start
we
with
can give
steroid,
steroid.
taper of
Steroid.
steroid, take a
Yes, ma'am.
steroid sparing medication. What might be that?
Mycophenolate can be given.
Mycophenolate can be there. We have used in our times cyclophosphamide in 1 or 2 episodes, then shifted to mycophenolate. So, can these patients with TMA who have anti-CFH antibody,
Yes.
you suppose get the anti-CHF and CFH antibody positive, will you
Yes.
look for genetic or not?
Yes, ma'am. We can look for genetic, mainly complement factor H
What
related.
type of, yes, what type of complement factor abnormality
Mainly,
can have
uh,
simultaneous with anti-CFH?
mainly CFH R1 to R5 will look for
Usually R1, R3. What type of duplication, deletion?
mainly look for
So
deletion.
deletion is the abnormality
Yes.
which you may have simultaneously on board with anti-CFH antibody positive.
Yes. Yes.
So this patient is now off dialysis.
Yes.
Would you like to do a biopsy in heart? What are the
Uh,
situation in which you will offer a biopsy in postpartum period? This is,
uh,
I will end here
yes, ma'am.
to answer this question.
If, if ma'am, renal function is not recovering, or there is persistently proteinuria is there, and there is active urinary sediments is there, or there is sudden onset nephrotic syndrome is there, then we can go for postpartum biopsy.
So whenever you suspect an underlying glomerular disease, you can go for a biopsy.
Yes.
Number two, when you are prognosticating that this partial recovery, whether it is going to recover or it will need some immunosuppression or uh, some other management, then also you can go for a biopsy. Suppose in a biopsy you find TMA with acute cortical necrosis. Would you go for any immunosuppression anymore?
No, ma'am. Actually, in these cases,
Yes.
50 to 60% will go end up in dialysis, ma'am.
Yes, yes. So in that case, we will not push the patient to any immunosuppression, but after a certain period of time, we will discuss transplantation.
Yes, ma'am.
Why this certain some period of time after which we will discuss transplantation?
Uh, because it will mainly it is because the TMA will active for next 1 to 2 years. It can recur, ma'am.
Suppose it is a lupus apla and progresses to ACN.
Yes.
Lupus lupus apla progresses to ACN.
Yes, ma'am. It's not hearing, ma'am. It's not audible.
If it is lupus apla and you find acute cortical necrosis, would you go for transplantation immediately or you will wait?
Ma'am, I will wait for minimum for 6 months to 1 year. Mainly, will wait for, ma'am.
Okay. So we wait for lupus antibodies to come down during dialysis so that
Yes, ma'am.
we have minimal recurrence of the disease post-transplant.
Yes.
What other
Yes,
disease
ma'am.
in pregnancy may get recurrence in post-transplant? Last question.
Uh, Pregnancy related, ma'am. First one is, ma'am, any complement mediated disorder like C3 glomerulonephritis or
Yes,
atypical HUS,
yes.
and
Pregnancy-related AHUS due to complement deficiency
yes, ma'am.
can recur after pregnancy.
Yes.
Yes. Thank you, Pratik.
Thank you, ma'am.
Thank you, ma'am. And it's an excellent class. So if you're in a hurry, you can leave. Otherwise, if you wish, you can stay.
I have to join the Wien meeting as well.
Okay, okay.
So
So just just 2 to 3 minutes. I'll be summarizing.
yes.
Dipankar today has presented a case of pregnancy-related acute kidney injury, which has recovered. And in the history, he was more or less complete. But the positive points and the negative points, especially during examination, and without going to the detail, is more important than everything. You need not discuss everything. Madam has told that. And in the initiation, she has asked you what are the other organs you have examined to rule out any systemic diseases like lupus. And in childbearing ages, it is important if you get any AKI in a pregnancy related in this kind of female, you should look for a lupus. And regarding the discussions on the preeclampsia, which was your first diagnosis, and she asked that when do we get a preeclampsia without any proteinuria, and in cases what is in severe preeclampsia and why it is different from a non-severe type of preeclampsia, and where the follow-up is more important, and what is the short-term medical problem that you can get in the patients of the preeclampsia or the eclampsia, and what are the less severe disease which usually recovers with the delivery. And what about the placental biopsy and the maternal kidney biopsy, about endotheliosis and about associated ATN she has also discussed. She has also asked you about the fetal outcome of these patients, why newborn babies, they are more prone to develop CKD due to the low nephron mass. And is the other types of the hypertensive disorders in the pregnancy, especially the chronic hypertension superimposed with the preeclampsia. She has asked you about what is gestational hypertension, and and a lot of discussion was done about the first trimester of the pregnancy, how it should be monitored even after the delivery in cases of the gestational hypertension as well as the postpartum, the preeclampsia or is a combined one. There is a regular monitoring of BP is important for a longer period. They may also develop a CKD, so monitoring of BP and creatinine at the interval that is required. And in these patients, this is unusual. She has asked about what about the normal BP changes in the pregnancy. You can miss in CKD patients having a pregnancy if you get a normal BP, because it is usually normal because of so many reasons. And any part of your diagnosis, there is AKI and that is recovered, that usually suggests this is an AKI, probably may not be an TMA. In postpartum TNA, there is a blood transfusions, but it also does not exclude this your CKD background diagnosis, because many of them has an anemic and require blood transfusion. History of nocturia is important. And regarding the next discussion about the abruptio placentae, how common it is, how it is not an HELP syndrome, even though there is a pain abdomen was there. Then in the investigation of common differential diagnosis of this abruptio placentae, she has asked about DIC as well as the patients in shock. About the coagulation abnormality, how it is different in the DIC in abruptio placentae HELP syndrome versus TMA, and where you get a diffuse abnormality in the coagulation or a selective abnormality of the coagulation. And why it is not a case of TMA, what about the LDH, and there's recovery, especially in this patient, goes basically against a diagnosis of TMA. Maybe most of them don't recover with 3 or 4 dialyses. And associated neurological disease, you should know about more about it. You should know something about TTP, how it is different from this TMA. Other type, this is a typical HUS. And what about this plasmapheresis, where it is more important to give in which situations, and in proteinuria in other glomerular diseases, how it is different from the lupus compared to preeclampsia, this amount of proteinuria. Then she has asked about the medications in hypertension, about the beta blockers which should not be used, about the side effects of methyl dopa, what is the abnormality, especially in the amniotic fluid with the diuretics. And some TMAs also can improve. What are those TMAs? What is antibody associated TMAs? How the plasma exchange is helpful in these situations? And if you have no eculizumab, how do you treat them? What about the role of cyclophosphamide followed by MMF, CFHS antibody, whether you should require also genetic testing in this subgroup of the patients, where you should do the renal biopsy, even though the patient is manifesting other diseases like glomerulonephritis, and you have to for prognostications for the therapy plan. And in acute cortical necrosis, you should not give any further immunosuppressions. And when the transplantation should be discussed in such kind of in such patients. And lastly, about what are the diseases that happens in pregnancy and recurs after transplantation. So probably, madam, you have discussed these points. So what about Dipankar? So what is the, should he pass in examination? Just a grading?
Yes, yes, he passed in examination.
Okay, okay. So
He will. I have highlighted few areas where he should read more.
Sure, ma'am.
yes. So with this, we are closing this case discussion, and we go to the next sessions of
Thank
the
you,
Oscars.
Pratik, for giving me this opportunity.
Thank you.
Thank you. Thank you.
Thank you.
So Aniruddha is there. Dipankar, you stay over, and he will show this OSCE questions. You have to read it and give your answer, and we can ask in between one or two questions, and at the end, Aniruddha will give an answer or some 3 or 4 slides what you should know for the purpose of examination and purpose of your future clinical practice, because you are going to be a consultant. So everything you need to read is not for the exam, for your life also. So this we have selected 3 or 4 questions. So over to Aniruddha.
Thank you, sir. I'll be starting the discussion. I'll be sharing the first slides. Okay, the slides are visible.
Audible.
Okay. So coming to the first question, Dr. Dipankar, can you go through the question?
You read it.
35-year-old female, hypertensive, second pregnancy, previous pregnancy complicated by development of pregnancy-induced hypertension, uh, preeclampsia. The low birth weight baby by LUCS at 38 weeks of gestation. Present pregnancy booked on second anti-hypertensive agent. And develops severe pain abdomen followed by bleeding per vagina at 34-week gestation. On evaluation, BP was around 90/60 millimeter of mercury, pallor 2 plus, fetal heart sound not audible. Uh, uh, Emergency birth segment cesarean section was done, followed by multiple blood transfusion, vasopressin, and there's intrauterine death of the baby. The birth weight of the baby was 2.7 kg. Post of anuric.
Yeah. So these are the investigations of this patient.
What are the important positive findings you are getting? Just tell. Yeah.
First is hemoglobin is in the lower level, and platelet count in POD 0 there is 1,50,000, but after that there is gradual decrease in platelet count. There is also transaminitis is there.
1,50,000. You just, that is not 1,50,000. The platelet count. Okay, okay. Next.
And there is gradual rising creatinine is there.
Okay.
Note the INRs and the
Bilirubin and INR is also and there is bilirubin is also in gradual in raising trend is there. So it can be
complement LDH and cystocytes are also.
yes, LDH is 288 and INR is more than 1.6. C3, C4 is normal and cystocyte is less than 2%.
the patient remained anuric and was on dialysis. Okay. So following this, the patient underwent a renal biopsy. So these are the slides of the biopsy.
It's looks like a acute fatty liver of pregnancy.
Is it a biopsy of liver?
First one is look like biopsy of liver, and the second one is look like it's a glomerulus. In first thing, the vesicles are there. So it can be acute fatty liver of pregnancy.
So you will fit, you can see these tubule-like structures. There is no portal vein visible. There is no hepatocytes visible. So do you think it's a biopsy of liver?
The first one, sir.
Yeah.
First one is
What are the highlighting lines? You can see these lines are highlighted. Only thing that is highlighted is this line.
it's a globules are there, some micro vesicles are there.
So this is the thing. And inside that nothing is probably visible. It is
Yes.
so can it be a tubule with or total loss of this severe type of acute tubular necrosis? Can it be there? The only basement membrane is visible and everything is lost. Nucleus is lost, cells are lost, brush border is lost. Okay, go to the second one. Other biopsy.
It's a glomerulus, sir. Is cellularity is normal, and there is no intracapillary thrombi is there,
Yes.
and yeah, and there is no, but there is in Bowman's capsule in the mainly the tubular side there is some micro vesicles are there.
So whatever the cellularity of the glomerulus.
Cellularity.
How a cell is diagnosed in the glomerulus? By their nucleus.
Yes.
So can you see any cell within this glomerulus?
So not able to sort of visualize.
Okay. So probably the cells are also lost. And you can see the surrounding tubules also. There is a gross destruction of the brush border. You cannot see the nucleus is over there also.
Yes.
Yes. So if you get a total acellularity in the structure, both in the glomerular side as well as the tubular side, so what is your, why it has happened in this patient? It's a postpartum AKI, completely anuric for quite some time, not like your case which has recovered. It has not recovered. Okay, Anirudh, let's go to the next slide.
Acute, can it be
You can take the help of this investigation and go back to
there is a bilateral calcinosis is there. So it etiologically it's look like acute cortical necrosis.
calcinosis is there. Your ribs are seen; those are calcium, and these white spots, they are not calcium. It is, what is this investigation?
There's a plain contrast CT, plain non-contrast CT showing a kidney which showing by
Do you feel it is a non-contrast CT, or you can see the liver vessel as well as renal vessel? Do you feel it is a non-contrast one, and also the vascularity?
Vessels are seen.
So this is a contrast CT scan. And what are you seeing in the kidney?
there is a cortical calcification is there.
Calcification is measured by the Hounsfield unit. You can just compare with the ribs. So do you feel these are calcifications or is a contrast enhancement? Bones all around, ribs, vertebrae, all are there. These are calcification. So what had not ossified in this part? Okay, Anirudh, you can tell.
Okay, so here what we can see is there is cortical there is hypoattenuation of the cortex. So the medulla portion has taken up the dye and the cortex is hypoattenuated. So this is a cortical rim sign or the reverse halo sign which is found in acute cortical necrosis. And the previous biopsy was of the acute cortical necrosis. In both these biopsies, we don't see presence of any viable cells or any viable nucleus, both in the glomeruli as well as the tubules. Only the basement membranes, the tubular basement membranes or the glomerular basement membrane has taken up the dye. The second image is by a James Silva, and the first one is by a Pass. So
Next.
with this, we come to the last part. What would be the etiological diagnosis for this patient?
Acute
Yes.
Acute cortical necrosis.
cortical necrosis.
Yeah.
So this is a common outcome of a postpartum AKI going to the acute cortical necrosis. Okay. Let's go to the next slide.
Go to the question, please.
A 35-year-old primary gravida with no previous comorbidities booked pregnancy at 23 week of gestation. BP was 140 by 100 millimeter of mercury. Dipstick showing albumin 1 plus glucose negative. At 27 weeks developed severe headache, blurring of vision, pain abdomen, and BP1 around 220 by 110 millimeter of mercury. Urine dipstick 3 plus glucose negative.
So USG with Doppler was done. What are the findings?
On USG Doppler, there is a absence of end diastolic flow.
This is the USG of Doppler of what? Is it a fetal Doppler or is a kidney? What will you see? You can see the fetus, huh?
Fetus.
Okay.
End diastolic flow is absent.
Okay. So what about the amniotic fluid? Can you see any fluid around this fetus?
Only, it's look like oligohydramnios.
Okay. So Anirudh, please.
Okay. So there is an oligohydramnios with reversal of the diastolic end diastolic flow. There is reversal. Yes.
Emergency LUCS 1.9 kg female baby. Postpartum, there is reduced urine output, anasarca. CVC hemoglobin is 9, total count is 18.4, and platelet count is 90,000. Creatinine 6.45, urea 157, SGOT 64, SGPT 43, bilirubin 1.8, albumin is 2.7, uric acid is 11.5, LDH 799, heptoglobin globin 106, urine routine examination showing protein 2 plus, RBC 3 to 4 in high power field, or Purcell 7 to 8. C3 is 112, C4 is 23.3. USG showing right kidney size is 10.1 centimeter and left kidney is 11.01 centimeter with mildly raised cortical echogenicity and CMD preserved.
So okay.
Positive findings are like counts is in higher side with platelet count is low, creatinine is in higher side with dense LFT, with slightly dense LFT, and there is LDH is also in much higher side, and routine examine and USG is almost normal.
Next slide.
In it's a biopsy, kidney biopsy with HE stain. There is in the glomes in the second biopsy. There is a intracapillary thrombi is there.
Which one? First one?
First one was yes. No, first one. The second one. Sorry, second one. Intracapillary thrombi is there.
So there is a fibrin thrombi with the red thrombus. Okay. So this is suggestive of
It's looked like a ATP TMA, thrombotic microangiopathy.
and first one it will.
Uh,
So what is highlighted in this biopsy? Can you see any? This time there is only cells, nucleus is visible.
Nucleus is visible.
You have all told in your last case presentation. So almost bloodless glomeruli. What is this? In cases of eclampsia, you can get this kind of biopsy.
So can it be, sir, intimal hyperplasia?
No hyperplasia. You told us endotheliosis. You are discussing
Endotheliosis.
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 And third one.
And third one, not able to, sir.
Okay, Anrito can summarize.
Okay, so the first biopsy, this is a bloodless stuff, glomerular stuff, where there is presence of capillary endotheliosis. The second one is with endotheliosis with intraglomeruli fibrin thrombi. And the third one is basically a sign in which, because of this lobular expansion, there is pouting. The sign is called pouting, where the glomerular loops or the capillary loops herniate through the proximal tubular end. Fairly specific wherever there is presence of endotheliosis.
So you are getting endotheliosis, fibrin thrombus, and this is pouting. And what is this? Okay.
Post cesarean section, persistent severe headache, postpartum, one episode of seizure like episode with confusional state. MRI brain, it's more or less looks like posterior reversible encephalopathy syndrome, PRACE.
Okay, right. Next. This is, you take the second question. What similar phenomenon can be found in other sites? Next.
Yes.
So we do.
What is this?
It's can be it's look like cotton wool spots.
Yes.
Arterial kinking.
There is
Look like
in preeclampsia, acute severe hypertension. This causes an acute endothelial defect in the brain. You are getting that edema. Here also you get the hemorrhages, exudates. That indicates acute endothelial injury. Okay, next. Okay.
After 24 hours, developed increasing weakness, lethargy. On examination, there is pulse rate is 47 per minute, regular, power 3/5, deep tendon reflex absent.
One line diagnosis, rapid, fast. Areflexia with bradycardia. You get a prolonged PR interval. TOF is not high. Okay, go to next slide. Is it important to know this ECG?
Can it be due to
Which electrolyte?
magnesium?
Yes, this is a hypermagnesiemia. Because in cases of the preeclampsia with AKI, you may get a hypermagnesemia. So before giving magnesium, that is important to know. If you give more magnesium in this patient will develop cardiac arrest.
Yes.
So other question?
With this ECG, what are the probable cause in these settings? It may be due to hypermagnesemia.
Yes.
Can any therapy related to this disease cause such finding? Can any therapy? During treatment of pre-eclampsia or eclampsia, if we give magnesium sulfate, then it can cause this type of findings. What are the risk factors present in this case? If there is any if any pre-existing any cardiac problem is there, or if without seeing any ECG, if we give without monitoring, we give magnesium sulfate, then it can causes this type of effects. Possible interaction between the antihypertensive and such therapy. If we give magnesium sulfate with beta, yeah,
If
no
you
idea.
give something which acts on calcium and you are giving in the hypermagnesium.
The calcium channel blockers,
Which calcium channel blocker?
mainly amlodipine,
Not dihydropyridine.
nicardipine. Sorry,
Nifedipine.
nicardipine, nifedipine,
Nifedipine.
nifedipine.
So what will happen if you give this?
If we give nifedipine, then it's block the calcium channel, so the effect of magnesium will be accentuated.
So if you give both magnesium as well as this calcium channel blocker, there is a chance of this is a fatal hypotension. So
Yes.
patient may develop severe hypotension.
Right.
Okay. What is the diagnosis? And we go to the next slide.
The final etiological diagnosis is mainly it's a magnesium toxicity. And what is the difference between hypertensive urgency? In hypertensive emergency, there is a severe, very high BP along with organ damage is there. But in case of hypertensive urgency, there is only very high BP, but there is no end organ damage is there.
So Aniruddha, next.
Okay. So this was the classification of the hypertensive retinopathy. The serum levels of magnesium with which the toxicity is attributed, and the risk factors for preeclampsia, in which in our case only nulliparity and advanced age was the main risk factors. Now come to the third question.
A 27-year-old primary gravida booked pregnancy. Antenatal period was normotensive and uneventful. At 30 weeks of gestation, taken up for LUCS, sitting cephalopelvic disproportion at 3.2 kg male baby. Post CS, there is reduction in urine output. Post op 24 hours become anuric. BP was around 170 by 100 millimeter of mercury. HD initiated, no seizure, headache, and confusion. And
The important points.
there is a important points are hemoglobin is in the low, platelet count is, or there is also thrombocytopenia, and there is gradual rise of creatinine is there, and there is also transaminitis is there.
Next.
What is the additional test? Sir, we'll look for LDH and INR is 1.2, LDH is
This is the LDH.
LDH.
Next.
LDH is
Go to next.
so we can go look for peripheral blood smear because there is hemolysis is there along with thrombocytopenia.
What are the
And
arrows?
also we can look for heptoglobin level.
In this slide, what are you seeing? The arrows are given.
These are helmet cells or cystocytes.
The fragment. You can see the RBC at the same time, fragmented.
Yes.
Go to
These
next
are-
slide. So this is the okay. Next. Read the biopsy fast.
It's looks like in the first slide there is a intracapillary thrombi is there.
you see something red, you tell about fibrin thrombi.
Fibrin thrombi.
Okay. Then what is next?
There is not able to recognize.
Okay, in the arrows area. Yes.
The next slide.
Next slide. Yes. What
There
is
is
what is the structure?
so, can it be sir intimal hyperplasia?
Not actually. You see the vessel, and what are you seeing in the vessel?
There is it's look like sir hyperplasia sir, but I'm not able to recognize.
Okay. Anirudh,
Okay. The fourth one. Okay, this is basically a fibrinoid necrosis. There is deposition of the fibrin-like material in the subendothelial layer of the arteriolar wall. It's not per se a necrosis, it's a misnomer, it's only deposition. And to differentiate from a necrosis, there is no presence of any kind of inflammatory cells. The second image, if you can describe. So this is an ischemic wrinkling or the ischemic collapse of a glomerular tuft, which is
sometimes you get this only. Okay. You see these patients after 8 weeks as a re-biopsy done, and you just read.
There is hyperplasia of the first slide. There is hyperplasia of the vessels, and in the uh, second slide there is duplication of the glomerular basement membrane is there.
Okay. So the probably patient is going to develop chronic changes.
Chronic TMA look like.
Chronic TMA. So probably the ultimate outcome is a CKD. Okay.
CKD.
Yes, Anirudh, the next.
Plasmapheresis given improvement in hematological parameters. Possible etiological diagnosis is like atypical HUS or with further we can go for further genetic tests like complement factor HBI, or you can look for genetic test for C3.
so in this case, a genetic workup was done, and this is the report which we have found. Okay.
Just give your interpretation. Okay, we don't have much time. So
So there is a complement factor H3, mainly complement factor H3 related. There is a mutation is there, mainly due to which a loss of function mutation is there.
Okay. So moving fast, the second test which was done for anti-factor H, which was negative.
Okay.
Okay.
so
Now,
yes, what identify this molecule? What is shown?
it acts as an alternative therapy to this particular condition apart from PLEX.
Eculizumab.
Yes.
Yes. Here is
In which step does this molecule act?
It's mainly act on when it's converted to from C5 from C5 converters in mainly step 2 it will act.
okay. Here is the step 2, and can you mention something about the dosage? How will you use, and any
Uh,
alternative drugs acting in the same step?
uh, so I mainly sir 500.
Okay, I wanted to go to because we are running short of time. So go
Okay.
to.
So this is the timeline of TMAs and the mutations again described by him, by Dr. Deepakar. The factor H mutations can be associated with C3 glomerulopathy also. And if you look at the terminal pathway, drugs like ravulizumab and normacopan also act on the C5. Now coming to the last question.
A 63-year-old male, hypertensive, on telmisartan for 40 mg, smoker. There is no other comorbidities. History of 2 episodes of red color urine 2 weeks back. Complaining of occasional abdominal discomfort. There is no history of pain in the flanks, lower urinary tract symptoms, pudendal edema. On examination, patient is conscious, alert. BP was around 140 by 90 millimeter of mercury, no pallor or edema. BMI is 31.1 kg per meter square. There is no renal angle tenderness. Dipstick is albumin 1 plus, RBC 3 plus. In important findings is albumin 1 plus with RBC is more than 100. Uh,
Keeping to
the
the
This is a 64-year-old male.
It's a 64 years male with active urinary sediments with hypertension. So it may be look like ANCA associated vasculitis. It's look like ANCA, or he's a smoker, so it can be malignancy.
So if you get a patient with overt hematuria in a 64-year-old, you will think more of a surgical cause or more of a medical cause?
First, we'll rule out the surgical cause.
Yes. So this for this, what investigation will you do?
First, we'll look for any cystoscopy. We'll do one ultrasound to look for any bladder mass is there or not. Then after that, we'll do one cystoscopy, and also we'll look for any malignant cells is present in urine.
So we have done something else. Show me, what is the investigation and what what we will see?
In left-sided there is protruding renal mass is present in left upper lobe and left lower lobe, and it's irregular in shape with it's more look like renal cell carcinoma.
So investigation is a contrast enhanced CT, and you are getting on a circumscribed mass, so on the lower pole only, left kidney, not in the upper pole. Okay. So next, Anirudh. So investigation.
Considering the radical nephrectomy, what precautions as a nephrologist would you advise? Pre-op DTPA, post-op renal function determinants. Left-sided spleen function is 43 and right-sided is 57.
So did you get the question? This is you are planning for radical nephrectomy. Now for that you have to plan for the rest of the life. He has to stay with one kidney.
Yes.
Yes. So what kind of planning will you do? Next. What is this? This is the DTPA scan
DTPA.
of post nephrectomy state. So what is the GFR now? Of the
67.
Okay. Go to next slide. So can you highlight something about this? What are renoprotective surgeries and the predictors of residual renal function? Okay, let's go to quickly, Anirudh.
So coming to the radical nephrectomy, the follow-up aspect. The patient after a year came and was found to have bilateral hilar lymph nodes on a chest X-ray. He underwent a PET scan which showed FDG avidity and active lesions. So what are the possible medical managements available for this scenario?
So basically post-operative metastatic disease. Okay. Go to next. So who are the candidates for non-surgical management and candidates for angioembolization? So you are aware of the non-surgical management of this RCC, metastatic disease. Go to next. Okay, next. So I wanted to just highlight this because this will all remain in the YouTube. We can always take this.
These was the causes of gross hematuria and the workup for them. So whenever we get a renal mass, depending on the nature of the mass, whether it's a complex cyst or a solid mass, we identify the nature of imaging what we need to do. If the EGFR is compromised, then a non-contrast CT or an MRI is preferred. But for a patient with preserved EGFR, always a contrast-enhanced CT is the investigation of choice. And patients in whom MRI CT cannot be done, MRI or a ultrasound, contrast-enhanced ultrasound can be done. And depending on the nature of the enhancement and the Hounsfield units, we can actually identify using a contrast enhanced CT whether it's a RCC and whether the RCC is either a papillary cell carcinoma or a clear cell carcinoma. And also based on the Hounsfield units, usually an angiomyolipoma can also be identified. So the basic risk factors in these patients are presence of tobacco exposure, hypertension, obesity, which was in our patient, and also the patient's prognostic factors, which we have described here, and the patient's is renal cell carcinoma because of its multiple paraneoplastic syndromes is also known as the internist's tumor. Now coming to the management part, as we were describing, it depends on the stage of the tumor, the classification and the size, and depending on that, usually stage 3 and stage 4 carcinomas need adjuvant medical therapies also and systemic therapies. And for the other tumors, usually radical or partial nephrectomy can be done. So coming to this management, which we highlighted as nephrologists, we should always advocate for nephron sparing approaches so that there is better EGFR preservation, and the candidates which need to be selected are mainly young patients or who have multifocal masses, whether if there is bilateral tumor or whether if the patient has a functional solitary kidney or if the patient has a pre-existing CKD or proteinuria. In these patients, nephron sparing approaches like partial nephrectomy or thermal ablation or tumor enucleation should be advocated. And in patients in whom there is limited life expectancy, the tumor size is small and the growth rate is less, active surveillance rather than a radical nephrectomy is advocated. Now, the portion which we described for a patient undergoing a partial nephrectomy and the patient undergoing a radical nephrectomy, the rate of EGFR reduction actually varies, and this loss of mass becomes a determinant factor. So the risk factors for advancement in the further increased progression of CKD is based mainly presence of baseline CKD, diabetes, hypertension, or proteinuria, when nephrectomy by ischemic injury and vascular injury causes further nephron loss, and also smoking and other neoplastic issues can result in progression of CKD. And for nephron sparing methods like partial nephrectomy, the ultimate renal function depends on the quality of the parenchyma which we have preserved and the ischemia time during the surgery, which, if prolonged, may result in worsening of the ultimate renal function. The surveillance part, as we described, there has to be certain clinical and laboratory imaging, clinical examination, physical examination, apart from certain laboratory investigations, and there has to be a routine imaging in terms of patients who have low risk. Then usually yearly within 3 to 12 months, there has to be abdominal imaging and chest imaging in patients who have advanced carcinomas or advanced stages. Their 3 to 6 monthly CT, ultrasound, CT or MRI has to be repeated on the abdomen as well as the chest to highlight for or to find out any metastatic lesion. And coming to the medical therapy for these, since it's time, multiple newer molecules have come up as targeted therapies, in which apart from tyrosine kinase inhibitors, anti-angiogenic factors like anti-VEGF inhibitors and immune checkpoint inhibitors have come up, and these immune checkpoint inhibitors nowadays have increased the spectrum of survival, and they are the first line drugs like ipilimumab, nivolumab, and pembrolizumab. And so over the timeline, we can see the advent of these newer molecules have increased the survival of renal cell carcinoma patients. And renal mass biopsy, which usually is contraindicated, should be considered only whenever we suspect a mass to be hematologic, metastatic, or inflammatory or infectious in nature. And for RCC, embolization is only done to control hemorrhage or to control pre-surgical hemostasis in cases of unresectable diseases, or if we have bilateral RCC to reduce the size and perform a nephron sparing surgery, these are taken.
Okay, we have kept this case basically as a nephrologist, you have to take the patients of post nephrectomy in a case of RCC lifelong. So you should have nowadays with the robots and with the laparoscopy, you have to have some say on the surgery, in the planning of the surgery, whether nephron can be preserved, whether the partial nephrectomy can be a choice, and what are the pre-operative evaluation, post-operative follow-up, and you have to know the immune therapies and the side effects related to the immune therapies, because we have to deal with the patients maybe creatinine going up because of the immune checkpoint inhibitors that may associate with interstitial nephritis, etc. So these drugs you have to have some idea, and the preservative surgery. That's why you have created this case. So we are almost at the end, and next 5 minutes of time, Dr. Aniruddha will highlight this some important trials in PRAKI, and this will be just only highlight, as there is not many trials in this session.
So coming to the trials, mainly the trials which were attributed to BP target in pregnancy. The first trial and the most important was the CHIP trial, that in which around 987 non-severe hypertensive females, already majority of them were having chronic hypertension, and they were divided into patient in groups and targeted on the diastolic BP, keeping the less tight target of 100 and the increased target of 85. So in this, the study, the finding was that the patients with less tight target had more incidence of severe hypertension, and severe hypertension was associated with further and higher incidence of adverse outcomes like low birth weight, preeclampsia, preterm deliveries, as well as thrombocytopenia and elevated hepatic enzymes. So in a way, tight diastolic control or the tight control of diastolic BP resulted in better pregnancy outcomes. So this was extrapolated, and the larger group of patients was included in this multicentric trial called the CHAP trial, in which more than 2,400 females were divided into two groups, and the patients in the control group, they were treated only when their BP went up more than 160 by 105, and the active group, in which the patients were targeted to keep a BP lower than 140 by 90. In this, the group with higher BP was found to have higher incidences of pregnancy-related complications like placental abruption, preeclampsia, as well as more incidence of preterm deliveries, as well as neonatal complications and low birth weight. So after this landmark trial, ACOG actually reduced the BP target to less than 140 by 90 when treating pregnancy in hypertension. So the trial, which concluding on working on the markers of preeclampsia, so it was a study called the PRASI study, in which the SFLT1 is to PIGF ratio was taken up as a marker for preeclampsia, and there was the study was done in 2 halves, a derivation cohort as well as a validation cohort, in which there was, in the derivation cohort, in patients having the gestation period of around 23 weeks and every 2 weekly follow-up, the patients having severe preeclampsia, there was the median value of SFLT1 is to PIGF ratio was significantly higher, and then this was tested on the validation cohort, in which this ratio, with a target of this ratio more than 40, was found to have significant negative predictive value, about around 96% of negative predictive value, rather than the value of positive predictive value of 65%. So coming to the eculizumab in atypical HUS, in which it was basically a single arm open label trial, in which 44 patients were taken up and were treated with IV eculizumab for 26 weeks, and at the end 38 patients were completed the entire trial, and hematological response in terms of platelet normalization and LDH normalization was seen in 98 to of patients, and renal response in terms of EGFR improvement was seen in 54% of the patients, and 79% of the patients who were on dialysis at the end of 26 weeks were dialysis free. So the complete TMA response, which they had given as the primary outcome of interest, was achieved in 73% of the patients, and at the end of 26 weeks, none patients were on plasmapheresis or plasma exchange. So finishing up with certain Indian, because mainly in Indian settings, case studies or the studies, observational studies regarding the etiology is available. Three studies which we could gather is these studies from South India, where the most common etiology epidemiology wise, through the epidemiology was 44% of the patients with preeclampsia, and in another study where the majority cause was puerperal sepsis, followed by a study which was conducted in Eastern India, where the most common cause was found to be sepsis, followed by TMA, followed by preeclamptic toxemia. With this, I would like to conclude.
Thank you, Dr. for this session. And so today in today's discussion, we have discussed a case by Dr. Dipankar Talukdar, a case of post-pregnancy acute renal failure. It was a nice discussion by Professor Arpita Rajchandri, followed by there was some cases was PRAKI. We just discussed repeatedly to clear the concept of this preeclampsia and association with the kidney. And we have kept one important case for the practical purposes, that is the case of RCC. And there are not much important trials available in this field, but whatever which are available had been highlighted. So your next, in few days, you can read at home total PRAKI as well as some RCCs and preeclampsia like that. So we are planning, as Mr. Shourav was telling, that we can make a written format of this and we can circulate to whoever wants that in the future. And yes, thank you everyone for attending the classes. Our next class probably will be on 20th, after 3 weeks, 20th of December. And thanks Mr. Shourav for organizing the whole thing, and also my thank to Mr. Amol for all this technical help, and Kuntal and Ashish is always my friend and they're there. And thanks everybody for joining the class. I hand over to Mr. Shourav.
Sir, only one thing, before we say good night, on behalf of the entire Regain PG Renal Classroom family, on behalf of the entire micro labs, I just would like to wish you a very happy birthday, sir. And may God give you more power, more healing power to to get your patients relieved of these renal nephrotic syndromes. And I really wish you many happy returns of the day. And with that, we'd thank you very much to take some time out from your busy schedule. Would like to thank you, Dr. Aniruddha. Would like to thank you, Dr. Dipankar. And obviously, thanks to Professor Rai Chaudhary from taking out some time from her busy schedule. Thank you very much, and see you next week with a new session. Good night, sir. Good night. Thank you very much. Thank you.